welcome to this important session on DNA fragmentation in male infertility. So, male factor infertility that contributes significantly to reproductive challenges worldwide. And in recent years, DNA fragmentation has emerged as a crucial parameter beyond conventional semen analysis. While standard semen parameters may appear normal, increased sperm DNA damage can adversely affect fertilization rates, embryo development, implantation outcome, miscarriage rate, and you can say overall ART success. Today, we will explore the clinical relevance of sperm DNA fragmentation, its underlying causes, diagnostic approaches, and how it influences treatment strategies in infertility management. I look forward to insightful discussion with our esteemed speaker, Dr. Shin, who has made significant contribution to the field of male infertility and reproductive medicine. With extensive expertise in sperm function, DNA fragmentation, and advanced fertility treatments. So, Dr. Shin, just a minute. So, Dr. Shin, he is an assistant professor at Department of Urology, Yokohama University, Japan. He has also served as a research fellow at Glickman Urological and Kidney Institute, Cleveland. He had been board of certified andrologist, urologist, and clinical genetist. He served as a director at Department of Medical Genetics, Yokohama City University Medical Center. Besides, he has been many awards he has to his contribution. The Young Andrologist finalist in 2025 at American Society of Andrology. And in 2024, he received academic research grant from Japanese Society of Reproductive Medicine. Besides, he has contributed to many research publications. Now it's up to the next voice would be from Dr. Shin, who will elaborate about DNA fragmentation. Dr. Shin.
Thank you so much. Thank you so much, Dr. Ritesh. Very kind introduction of myself. So let me share my slides. Okay. Now, do you see my slides? Sorry. Oh.
Yes, we are able to see your slides.
Okay, great.
Excuse me, Dr. Shin.
Yes.
We are able to see your presenter notes also.
Okay. Let me check. So,
yeah.
Okay, now do you see the presentation slides? Okay.
Yes, yes,
perfect,
it's fine.
Perfect. Okay. So good evening, everyone. I'm Dr. Kuroda from Japan, Yokohama City University. I'm so excited for this opportunity as a speaker in this webinar with the people with Indira IVF. I really appreciate all the arrangements and help from people in Bolivia also and everyone. So let me start with some introduction slides quickly. Okay. I have no, this is my COI. And Dr. Ritesh already introduced myself in detail, so I do not need to speak about myself a lot, but I'm a urologist and specializing in male infertility. And so I have spent most of my time in my career in clinical practice, but I am also involved in like clinical research and also translational research about male infertility. It's sometimes about sperm DNA fragmentation and also genetics. And yes, a lot of topics I was lucky to be involved in many researches. So let me introduce my affiliation a little bit. So my university is located in Yokohama, which is next to Tokyo. It's kind of center of Japan. We have 2 university hospitals, and our university has over 160 urologists. And in addition to university hospitals, we have 26 satellite hospitals around the cities. And I belong to YCU Medical Center on the right side. So here we do robotic surgery. I mean general urology, but we have some specialty sections for male infertility and men's health, and kidney transplantation and pediatric urology. So this is the center I'm working, the Center for Reproductive Medicine. We have such section in the hospitals. So we are working like a team with gynecologists and urology. So it's like combined as a one section. And this is the cases of last year. This may not be so many compared to like high volume center all over the world, but we are academic affiliation, so we do some clinical research ongoing. And so, yes, so this is the cases, okay. And for myself, I had experience in Cleveland Clinic in the United States between 2021 to 2024. I spent 3 years there, and I have worked with like many people, and I was involved in like multiple studies, including clinical research and translational research related to sperm DNA fragmentation. And yes, this person is Mr. Edward from Bonravio. So this is the first time I met the first people from Bonravio, and I was involved in the validation study to examine their new SCD kit that I want to explain in my presentation later. Okay, so this is my agenda for today. So I believe today's audience are mainly IVF specialists. So I like to explain about like male infertility a bit and move on to the sperm DNA fragmentation. So infertility is well known as a worldwide issue, and 15% of reproductive age couples are reported to be infertile. This pie graph is really famous from WHO and also a lot of global guidelines. And based on this, male factor contributes to 50% of such patients. It means that we have a large population of patients all over the world. And on the other hand, the number of specialists like me of andrology, urologists specializing in andrology are very few. So like, for example, in Japan, we have a population of 120 million in the country, and board certified urologists are over 7,000, but we only have 80 andrologists board certified here in Japan. So, and this is the breakdown of cause of male infertility. This is from Japanese national data, but I believe this is very similar to all over the world. And based on this, the common cause of male infertility is idiopathic. It's like a 50%, like 40 to 50%. So this is This means like unknown cause. So where we do not have like one-to-one treatment, like specific treatment, we cannot provide any specific treatment based on evidence. So this is the main issue of our field. But although we can, like we have, fortunately, we can advise them to proceed for IVF or ICSI. So we do have such technologies. But so this to unveil this pathophysiology is a main issue and our challenge in this field. On the other hand, varicocele is the second cause of male infertility. So for this pathophysiology, we do have a treatment, which is surgery, and with a very robust backbone evidence. So when we find this, we actively treat this disease. Okay. So let me explain a little bit of varicocele here. So it is found in 35 to 40% of male with poor semen parameters, but it is also seen in all men, 10 to 15% among all men, regardless of fertility problems. So it is kind of common status, which is, we can say, abnormal dilation of the venal plexus around here. It is called pumpiform plexus within the scrotum. It resulting from reflux in the internal sphenic vein. So in some patient has the reflux of this internal sphenic vein. So blood flow goes like this. So it impairs spermatogenesis through it causes heat and also hypoxia and oxidative stress. So this is more explain about the mechanism of pathophysiology. So if the patient has varicocele, so like on the picture on the right side, so it causes scrotal hypothermia. So actually we can see temperature elevation of scrotum. And also it causes reflux of metabolites, and it causes testicular hypoxia. So they all goes to elevation of reactive ROS, reactive oxygen species, which is like biological substances that causes oxidative stress. Oxidative stress imbalance causes sperm DNA fragmentation and also membrane peroxidation, which results in the lower sperm motility and impaired sperm maturations. So thus all of these leads to impaired sperm quality. And we do have treatment for this pathophysiology. It's a surgery called varicocelectomy. We use a microscope and we ligate all the internal spermatic veins like this. But at the same time, we preserve arteries and lymphocytes. They are important to improve semen parameters, actually. So by blocking the retrograde blood flow, so we can do elimination of thermal and oxidative stress. So this surgery can improve semen parameters, which is like concentration or motility, and also sperm quality, which is not reflected in conventional semen parameters. But many studies have shown that it also improves like sperm quality, such as sperm DNA fermentation rates and the oxidative stress status. So it is said that about 80% of the patients can have a benefit. So it's directly reflected in their semen parameters. About 20% of the patient they do not have this really significant improvement in semen parameters, but they still have improvement in sperm quality, which is supported by many studies. So this is a recent systematic review and meta-analysis about the impact of varicocele repair on ART outcomes. So based on this, surgical intervention for varicocele significantly improved pregnancy rate and also rebirth rate in ART settings. So even if you cannot aim like step down by significant improvement of like sperm count or motility, but they can still improve the sperm quality, resulting in the improvement of like reproductive outcomes in ARTs. So in any settings, when you find the varicocele, it is better to treat it for the reproductive outcomes. Okay. So varicocele is a treatable pathophysiology, I can say, with robust evidence. But as I mentioned in the beginning, our leading cause of male infertility is still idiopathic. It occupies like 30 to 40%. And so we need to unveil pathophysiology, increase treatable population. And also, it is linked to this fact, but we do not have well-established biomarker other than conventional semen analysis. So it has been used like 30 to over decades, as you know, but other than semen analysis, we do not have really well-established, which is clinical beneficial biomarker. So we do not have it yet. And also, this graph is come from one study that is showing semen parameters daily change of one patient. So semen analysis actually has really poor repeatability, as shown here. So sometimes it's really good, but based on like condition and also limitation of the test itself, so it has really poor repeatability, unfortunately. So we need to unveil pathophysiology to increase treatable population, as I said, and also we need to investigate reliable biomarkers with good repeatability and to reflect more precisely to reflect the sperm quality or like fertilized. So sperm DNA fragmentation is really common now biomarker, and which is known to be a biomarker to reflect sperm quality. Actually, it has been widely used in the last 20 years, either in like research settings or clinical settings. And so far, multiple meta-analysis indicates that it may affect reproductive outcomes. And the latest WHO manual, for the first time, it stated that this sperm DNA fragmentation is becoming one of the most discussed and promising biomarker in andrology. So this is the explanation of sperm DNA fragmentation. It has like single strand break. So as you know, the DNA has a has double strand like this, and single strand break. It has by multiple cause. Sometimes single strand of DNA just break like this, or double strand breaks. So to test the sperm DNA fragmentation, currently we do have 4 types of SCS assays in the world. It is tunnel, SCSA, and SCD. It is also known as like hollow test or comet assay. So WHO 2021 manual, for the first time, they described the detail of their principle. And they are based on very different principle and different actually cutoff lines. So which is yes, okay, sorry. And the WHO has not defined which is the best test, and states that they also saying that the test should be chosen based on the accessibility of each clinic or hospital. So we cannot say which is the best test, and then you can choose the test based on your accessibility actually. But in general, tunnel and SCSA usually they need a flow cytometry, which is a very complicated test, and also the equipment is expensive. So it's like small clinic, the older clinic cannot afford it actually. So usually they throw the sample and send it to the center for the test. And on the other hand, SCD or comet assay, usually they don't need a flow cytometry. So they can be performed even in like clinics or like hospitals. And then DFI is described as a DFI. So DNA fragmentation index, which is calculated by fragmented sperm divided by total sperm, which is a percentage of fragmented sperm. So we need to calculate the percentage of fragmented DNA, sperm with the sperm DNA fragment. So SDF and sperm parameters are known to negatively correlation. In this study, DFI showed negative correlation with semen parameters. Like this, like sperm concentration, morphologies, motilities, they are showing the vitality test results as well. Actually, there are many studies showing similar results. So it's not the only one study, but many studies have shown that DFI negatively correlates with semen parameters. And this one is similar results, similar study, and showing that the group 0 is a normal semen parameters population, and group 2 is more than, they have patient with more than 2 abnormal semen parameters. So group 2 has a significantly elevated DFI compared to group 0. So which shows the similar results as previous study. But when we focused on this group C, so which is the group with elevated DFI, more than 30. So a certain portion of men with elevated DFI still exhibit normal semen parameters. So this suggests that conventional semen parameters alone may not fully reflect like sperm quality, I mean sperm functional integrity or fertilizing potential. And SCF is also known that adversely impacts embryo development. So this is a pretty famous study in 2004, but the embryo development is in the beginning, they are based on the maternal DNA, maternal factor. And as they develop at the stage of cleavage, like early embryo, so zygotic gene activation happens. And after that, the center of development switch to embryonic factor. It's like a combination of maternal DNA and sperm DNA. So when we have the sperm DNA fragmentation, we will have the poor development of blastocyst. It is called late paternal effect. So it's not only relations between conventional semen parameters, but they impacts embryo development as well. So this is one review which I was working on at the time of Cleveland Clinic. And we have summarized all the systematic review and meta-analysis. So there are so many papers, like meta-analysis. They are all meta-analysis. And they have shown that high SDF is negatively correlated with any types of reproductive outcomes, like this one is natural pregnancy, IUI, IVF. So all of them. So those meta-analysis show the negative impact of sperm DNA fragmentation to each reproductive outcomes, and also embryo development. So we do have pretty robust evidence that it impacts, actually impacts to the reproductive outcomes. But on the other hand, global guidelines, such as AUA, ASRM from the United States, or EAU, SRED, so they do not recommend routine SF testing for initial evaluation. So we are not supposed to provide this test like routinely for their initial evaluations. But they also say that it can be considered in specific scenarios like a repeated pregnancy loss or repeated ART failures. So the reason is that the lack of prospective evidence. So as I showed in the previous slide, we do have a lot of meta-analysis, but the conducted study they have a limitation. We still lack a really high quality study like prospective evidence. And also, so each SF testing assay has different cutoff values. So cutoff inconsistency is also the reason that it is make it more difficult to be to create a definitive evidence. And also, we still have a lot of idiopathic male infertility. So even if we know that this patient is elevated DFI, in most cases we do not have direct one-to-one like specific therapeutic intervention to decrease the level of DFI. So we in any way we need to provide precise clinical evaluation for male partner. So we need to do a physical examination to check if the patient has varicocele, or we need to check their hormonal status. So those like routine initial evaluation can be done with or without testing SDF. So those are the reason the global guidelines are not strongly positive for this test. But this paper is just published by Dr. Esteves on the human reproduction. So this is a really good review to explain about the sperm DNA fragmentation test. So the indications, when to test, and what to do. And in this paper, the authors, are more positive for the SDF testing, and they have a lot of indications for SDF testing as listed here. So like unexplained idiopathic or idiopathic infertility, which is also recommended for in global guidelines, and RPL, failed IUI, and also this is like repeated ART failure or poor embryo development, which is suggesting that late paternal effect. And in some clinical varicocele cases, it is useful to think about the indication for the treatment. So some patient has like normal semen parameters, but they have the history of infertility. And if the patient has varicocele, and that's from DNA fragmentation test showed like elevated DFI, so they can proceed for the SDF, varicocelectomy, and we have the possibility to improve their fertility status. So like this type of like in specific scenarios, it has a benefit to provide these tests for sure. Sorry, and then global guidelines also started to discuss about the repeated ART failure. So this is like very difficult case for all of us. But so this is also written by Dr. Esteves, but it is also known that testicular sperm showed lower SDF than ejaculated sperm, especially in like very severe oligospermic patients. So if the patient has a history of repeated ART failure and the patient has an elevated DFI, we could consider about using testicular sperm. But it is still controversial, but guidelines, this is in my opinion, but guidelines started to be positive for this option, treatment option, because for the couple with a repeated ART failure and high TSF, so we could provide testicular sperm via TESI. Sorry, I have been speaking a bit quickly, but this is a short summary so far. So SDF is strongly associated with reproductive outcomes. And SCF is considered as a potential more reliable marker to reflect sperm quality than conventional semi-parameters. So although routine SCF testing is not recommended for all infertile men, it may be useful in selected clinical scenarios and clinical to guide like clinical decision making, such as in clinical varicocele, as I mentioned, and treatment strategies. Okay, so from here, I'd like to focus on SCD test. So although those like tunnel and SCSA are like in Japan, I believe SCSA is now most common assay in the current marketing, but those two needs flow cytometry to run the test. But flow cytometry is really expensive, and actually the technologists to run the test is really need to be trained. Like training curve is really difficult, and so not all the clinic can afford it all by themselves. But SCD test can be performed like without flow cytometry. The principle is that to involve to stain and evaluate the halo formed by DNA naturation using acid solution and lysis. So when you remove the protamine with the lysis solution, so DNA loop dispersion is occurred, like in this picture A. So when the DNA is not fragmented, if the DNA is not fragmented, the halo can be seen like picture A or B like this. So on the other hand, if the DNA is fragmented, the halo is not formed like C or D. So it's like C or D. And then after the staining, in conventional method, we count manually like 300, more than 300 sperm and evaluate more than 300 halos and calculate DFI. So if you see it like A or B, so like big halo, so they are not fragmented. So they just count, we just count the number of halo and calculated the percentage. So this is the method. Actually, it's really simple and inexpensive. And so when you like try like several times, I think you can get used to it. But what is this advantage of this test is like halo evaluation is sometimes like subjective. And also it is difficult to evaluate a larger number. Like if you do it manually, it is very difficult to evaluate like 10,000 or 100,000. It's impossible. So basically it is a test to evaluate smaller number of sperm like 300 to 500. But if we utilize a computer or AI-aided system, we could overcome this disadvantage. So this is the code. This is the product called X12 Pro. So they will read the stain slide automatically, and they detect all the halos and count and calculate the DFI with really short time, and it can evaluate halos more than 3,000 sperm. So they can see the full of slides, so they can count all the halos like within. It depends, but within 3 to 6 minutes for one well. So it is pretty convenient. So they capture the image like this and recognize objects if they are sperm or abnormal staining, and also calculate the size of halo compared to the size of sperm head, and they classify halo as a fragmented or non-fragmented and calculate percent DFI. So I was involved in a validation study of this technique, and also so R10 is like a new SCD reagent kit, which is we can stain the halo more clearly actually compared to a conventional method, and the staining time is shorter actually, and also it can be combined with X12 Pro, which I explained in the previous slide. So this method, I perform agreement analysis between each conventional method like SCSA or tunnel and halo sperm, which is another SCD method. So the obtained percent DFI by this method correlated and agreed significantly with existing all the existing SIF testing modalities. So we concluded that they could evaluate a higher number of spermatozoa in a short time compared with the conventional SCD. So 3,000 or 5,000 is pretty close to the number of spermatozoa which is evaluated through flow cytometry. So the number is close to flow cytometry, and they can be done much easier. Okay. So then another topic is double-strand sperm DNA breaks. I introduced this in the previous slide, but sperm DNA fragmentation is divided in single or double like sperm DNA break like this. And I think it is easy to imagine, but if the double-strand break happens, it's more difficult to be repaired. So we like when they sperm fertilize the egg, so egg or oocyte has the capacity to repair the sperm DNA fragmentation, but double-strand break is easier compared to single-strand break, easier to exceed such capacity, so which resulted in so they cannot repair the fragmentation, so which result in a poor embryo development or reproductive outcomes. So it is caused more by direct way, like nuclear matrix attachment region damage or meiotic repair failure, and a lot of causes are written here. And so now some recent study has been focused on stronger association with reproductive outcomes than single-strand break or global DNA global SDF, which means that the combination of the sum of single and double strand break. So especially the group which is good at the comet assay has been reported that double-strand DNA breaks associated with adverse reproductive outcomes, such as recurrent miscarriage and or recurrent recurrent pregnancy loss. So I'm sorry, I'm going back to this slide. So among these four, only comet assay can detect it has previously comet assay is the only one assay they can detect double strand break fragmentation breaks. It is called like neutral comet assay. It is that they use a neutral reagents to see only double strand break. So those studies have shown that DSB is significantly associated with especially recurrent pregnancy loss. So studies started to show that DSB has potential to be a direct marker to reflect more like direct outcomes, I can say, like RPL and reproductive outcomes. And this is, but recently, using it is similar to SCE test, but it's a little bit different. But this technique has been developed to detect DSBs. It is the product name is R11, which I have been using in criminal clinic, or actually I'm now using it for research purpose. But so they can detect only DSBs by halo forming. So the strategy is opposite. So if we different from conventional SCD, in R11, if the sperm has double strand break, they forms halo. So it's completely opposite to a conventional method because so usually SCD shows halo when the sperm DNA is not fragmented, but here the sperm has halo only when the sperm has double strand breaks. But anyway, it is a more convenient and easier way to test the double strand break. And the study on the right side also showed like similar to the previous study. So they shows that they could predict the miscarriage rate using double strand by measuring double strand breaks. And the AUC was 0.7, which is feasible results actually. So this is not in WHO manual yet, but this technique only detects DSB in a simple technique similar to SCD, but it has a potential to predict like miscarriage rates, like more direct reproductive outcomes. Okay, so this is my last slide. So the take-home message. So despite its limitations, SCD holds potential for greater inclusion in clinical guidelines for male infertility. But we still need like high-quality clinical trials. So they are essential for standardizing the choice of SCD assays and appropriate DFA cutoff values. And I focus on SCD this time, and SCD is a simple assay to test sperm DNA fragmentation. And when combined with X12 platform, it allows for objective evaluation of a larger number of spermatozoa compared to conventional SCD methods. And we still need more evidence, but double-strand DNA breaks may be more strongly correlated with reproductive outcomes than conventional DFI. and have attracted attention in recent years. Thank you for attention. I'm open to any questions. Thank you very much.
Thank you, Dr. Shin, for such an insightful journey through the various pathological conditions associated with DNA fragmentation. And I think you have tried to cover all the aspects of the DNA fragmentation. And in fact, nothing was left. But still, if somebody has any questions, you can raise your hand, or please, it's better that you type it in the question in the chat box, and we'll start taking questions one by one. So,
okay, maybe we have a question in the chat.
Okay, yeah, in the chat. So you want me to read the question for you, or you want to read it yourself, Dr. Shin?
Okay, yes, I can read it. Please give me a minute. Okay, so if small DNA fragmentation is strongly associated with recurrent ART fatal miscarriage, why do many fertility centers still rely primarily on conventional analysis?
So I'll just read it for the rest of the people. So the question is that if DNA fragmentation is strongly associated with recurrent IVF ICSI failure, miscarriage, and poor embryo development, why do many fertility centers still rely primarily on conventional semen analysis while advanced sperm DNA integrity testing remains unutilized in routine male infertility evaluation?
Yes. Yes. So I think that this is my personal opinion, but the conventional semen analysis still has some role, and they have some like strong point to directly assess the motility or count, so we can change our indication, the choice of treatments like IVF ICSI. But I think we still need more robust evidence, but I think it is better to combine the sperm DNA fragmentation. So not only just one, but we need to combine all the information which can be acquired by conventional semen analysis and also sperm DNA fragmentation. I think that is the best way to evaluate like infertility status, like potential.
Dr. Shin, in your opinion, what do you think that should it be made mandatory along with this routine semen analysis, or it should only be ordered on in case of indicated cases? In one slide, you have shown the indications for sperm DNA fragmentation. So it should be done only on indicated cases, or it should be mandatory for all the infertility workups?
Yes. So yeah, I know some clinics almost perform the sperm DNA fragmentation test routinely. But in my opinion, I think we still select the case or scenarios for to provide the test. Not routine. It is the routine test is still not recommended in the guidelines, and but they have. I really know that they have the potential to change our indication. Like if the patient has like elevated DFI with repeated IUI failure, like so they fail like 2 or 3 times, and if the DFI is high, maybe they can proceed for like IVF ICSI earlier, right? So like in such cases, so we still need to choose the scenario.
Okay. So, and the next question is that's quite relevant. And the next question is pertaining to the my clinicians. They often ask me what Helen is asking, that current management options for patient with severe SDF. So what in case the DFI levels are too high, and what are the treatment options, or what are the options for that?
Oh, sorry, I lost the question. Is it in the chat? Sorry.
Yeah, it's in the chat. The next question by Alan. It's current management options for patients with severe SDF.
And budget option for serious. Management, sorry, yeah, management options for patients with severe. Is that right? Doctor, okay.
Yeah, that's the question.
Yes. So we still need to go back to the precise evaluation of the male partner by physical examination to check if the patient does not have like varicocele. If the patient has the varicocele, we have the chance to reduce the DFI. And also if the patient has like bad lifestyles like smoking and obesity, or like such like precise evaluation is definitely needed. But like so as you know, like in ICSI or ART cases, so some clinics start to use like sperm spallation kits to reduce the percentage of a high DFI spermatozoa. So that might be the one management options. And also in the case with like a repeated ART failure, even if you use the such sperm spallation kit, so we still fail and fail. So we could consider about, if the patient has a high elevated DFI, we can think of using testicular sperm by testicular sperm extraction. So that is still controversial, but so that guidelines are getting positive attitude to do like such options. Is it okay? I hope I'm answering your questions.
Okay. Okay. So yeah, definitely it depends on the underlying cause. So it is better to treat the underlying cause, and that is the best
Yes,
treatment for
exactly. Yes.
DFI. So next question, just a minute. What are the solutions for higher DFI in advanced paternal age? So, what can be done? Okay, so if it is a pathological condition, that can be treated. But what in case of advanced paternal age? How to manage with those cases?
Advanced paternal age. I don't think we really do not have the direct solution for the advanced paternal age, because so we cannot. But we so a solution for.
So is
Yeah.
there any threshold that we can label that this is the advanced paternal age? So first, I want to understand what is the definition of advanced paternal age. So after what age we can think that yes, the DFI is high, it is because of advanced age. So is there any threshold for age as well?
Yes. Like so for male partners, it really depends on the individuals. Like it's different from female, but is now 35 years old is considered as one threshold, because so we have the study actually in the past. We have the study that so compared between so after 35 years old, the convention the swimming parameters getting worse. It's not.
Okay.
They are not really rapid change as compared to female, but after 35, including sperm DNA fragmentation, they become worse little by little in men.
Okay. Okay. So you mean to say it is again just like the female counterpart, 35 is the definition of advanced paternal age.
Yes, one of the thresholds. Yes, I can say yes.
Okay.
Another study
Okay.
has like over 40 years old. One study shows that there is increased rate of autism for their offspring. So it's I think it's a little bit different topic, but after 40 years, so the percentage or probability of autism in their offspring increased. There was a study showed that.
Okay.
Yeah.
Okay.
So 35 or 40.
35 or 40. That's and is there anything we can do in those cases, like in advanced paternal age? Is there anything we can do to reduce the DFI, or it's just the antioxidants or something like this?
Yes. But we always need to go back to find underlying cause, regardless of age. But like supplements, including vitamins, coenzyme Q10. So for those we have tons of papers in previous studies, but we see lacks really high quality evidence. So so in my practice, I recommend not strongly, but I recommend such supplement especially for paternal age patients. Sorry, I'm advanced paternal age patients, but they still lack really robust evidence yet.
Okay.
So
Okay.
yeah, so we may need to discuss about like sperm freezing at the time of the young age, so which is now becoming common in female. So we still need a lot of debates, but so one possibility is to freeze the sperm at the time of the young age.
Right. At younger age, sperm freezing is one best solution.
Yeah.
If you already know that you are not going to produce a child till the late age. So
yeah.
Okay.
We still need a lot of evidence, though. Yeah.
Next, coming on to the next question from Mansi Singh. Maybe Preta, yes, you can read out the question.
Yes, sir. So
So many questions.
Mansi has said, sir, as you mentioned in this presentation, that in case of high DFI and ART failure, we use testicular sperm. Is this the only way to tackle the problem?
Yes. So I think the evidence is limited, but you could utilize like sperm separation kit like Zymote or CA0. Maybe it's common in your hospital too. But so before proceeding surgery, you could do such like separation technique. And if it doesn't work, I think that's the only way to proceed for the surgery.
Okay, so here I would like to ask you, which kind of advanced sperm selection technique would you, recommend for, trying to get better IVF outcomes or ICSI outcomes? Do you think we should use microfluidics, or should we lean in towards MAX? Or should we do Pixie? I mean, there are multiple methods and multiple studies that say a lot of things about it, but it is a little contradicting and controversial. So, what do you think, in your opinion, is a better sperm selection method here?
It's very good and difficult questions, actually. I completely agree with you. There are so many, techniques and so many papers that insisting that their technique is good, like, but still, so we still lack really robust, like prospective, high quality evidence. So yes, so it's difficult to choose one, but yes, そうだな. Yeah, in my hospital, they sometimes use like microfluid technique in selected cases. But the other, yeah, so that's kind of our opinion.
Right, right.
Yeah,
So I think it depends on the lab who's performing the
right.
procedure and which technique they want to go through, and
Yes,
that gives them the better result. Okay,
that's right. I agree. Yes.
all right. Okay, so moving on to the next question then. Uh, Regarding SDF testing and oxidative stress assessment, both seem to be most useful in selected clinical contexts. In your view, which of these two tests currently has greater practical clinical utility? And if both are relevant, which test would you prioritize in your routine practice?
Okay, thank you for the question. Yes, if you want to prioritize one of them, I would say like we want to prioritize sperm DNA fragmentation because it has a more direct impact on the outcomes. Actually, oxidative stress can cause DNA fragmentation, but SDF testing can directly assess the sperm DNA fragmentation status. So if you need to choose one, I would say I would prioritize SDF testing. But oxidative stress can also cause like peroxidation of sperm membrane, which is cause lower sperm motility. So if you can assess both, there's no harm, and it may be better, like regardless of cost and everything. But yeah, that's my opinion.
All right. So since there's less time, I'm moving on to the next question. So
Yeah.
Dr. Sanath has presented a case actually. The male partner has a DFI of 35%. Other parameters are normal. There is no female factor infertility, and couple has a history of natural conception and 8 first trimester abortions. Karyotype of both the partner is normal. CMA and WES of product of conception shows no significant anomalies. How to proceed in this case?
Oh, it's a very difficult question. Yeah, I think this doctor's view is to consider about like using testicular sperm for such cases. Yes, so yeah, I think so. In general, it's difficult cases with high DFI, like 35%. For those cases, regardless of detailed background, we could start thinking about using sperm, like testicular sperm. So I know it's invasive options, but if the couple experience like repeated failure, I think that's one of the option. Although it's invasive and it's not comfortable for the patient for sure. But yeah, but I agree. I think there's no one answer for this scenario. It's a difficult case.
Right. Uh, so Helen has asked another question. She says, is there any clinically significant effect of antioxidants in reducing SDF?
Because the effect of reducing. Yes, there should be many papers regarding this topic. So antioxidant can reduce oxidative stress, like to adjust, they can adjust sperm oxidative stress, and which results in the reduction of DNA fragmentation. So, but we do, yeah, it's, but we still need more high quality evidence though.
So, do you think based on the underlying causes or mechanisms, we should, target different antioxidant therapies, we use different antioxidants for different cases? Is there something like that that can happen or is happening right now?
You mean the types of
Yeah,
the
yes, different antioxidants being used to treat different, different underlying causes. Or it varies from for the patient profile when you take history. Does it differ, or is the same cocktail just used for every patient who has to be given an antioxidant therapy?
yes, this is very my personal opinion, but there's no big difference between any like integrating ingredient like vitamin C, E, or like we have access tons of papers regarding such topics. Like so, some paper has focused on motility and like sometimes vitamin C or E. They show the improvement in the motility, but not in concentration. Like so, we have such small studies or retrospective study, a lot of studies, but they are not high quality already, unfortunately. So I in my opinion, so they are all based on limited evidence. So I do not, but I try to choose most robust evidence, antioxidant with most robust evidence. Like so, in my opinion, like coenzyme Q10 has so we still lack of a lot of evidence, but we have some like decent papers related to coenzyme Q10. So, so I try to choose such antioxidants.
Right. Okay. So, so now we have reached almost to the end. There are two more questions remaining. One is in a couple with recurrent implantation failure but normal semen parameters, how much weight would you give to DFI before modifying the ART strategy?
Let's see. Regarding implantation failure about normal parameter, how much weight should we give to DFI before? Recurrent implantation failure. Yeah, I think in this case, we should consider about testing DFI, and but so first of all, the male partner should be precisely like evaluated by like its specialist, like to check if the varicocele, if the patient has varicocele, I really recommend to take that surgery to repair the varicocele. So first, male evaluation. So it should be done. It always should be done parallelly, ideally in the beginning of the treatment. So at the
Right.
start point.
Right.
So and but they still there's no other underlying cause, but they still have high elevated DFI. I think in this case we should check and think about the strategy, like to modify the strategy.
Right. So we should take a proper history, get the male evaluated properly before proceeding on or the management strategy.
Correct. Yes.
Right. Okay. So the next question is, how can abstinence increase DFI? Does pH have any role there?
Oh, abstinence. Okay, can I
Abstinence,
drink? Yes. So I always recommend to have shorter abstinence days for the patient, like 2 to 3 days. There is a study that it should be less than 3 days. And also, I think recent study, especially in ART settings, we do not have a lot of. We really need a like high quality sperm, even if the count is lower. Like if the abstinence days is like 0 or 1, there's a tendency that to have like lower, a little bit lower concentration or volume. But in ART settings, we do not a lot of sperm, but we really need, even if it's a small amount, we really need a high quality sperm.
Right.
So yeah, so I always recommend to have like shorter, especially in the ART setting. I think the abstinence days can be like 1 or 2 days, like less than 2 days.
Right.
Yeah.
Okay, so people when they
yes.
come for IVF or ICSI, they should have a shorter abstinence, ideally 1 or 2
Especially,
days
yes.
abstinence only. Okay, all right. So I think by this we have reached the end because some of the questions are a repeat of previously you have already answered.
Yeah.
So thank you so much.
Yeah, thank you so much for a lot of questions. I'm really impressed. Yeah, they have a lot of interest in this topic. I'm happy. Yeah.
Yes, this
So,
is majorly
thank
a
you.
topic of interest.
Yes.
Thank you, Dr. Shane, for your valuable time and taking out time from your schedule. And it was, although it was an evening, and I hope you had your dinner. I have heard that Japanese people they take dinner very well in time.
You're right.
Yeah. So
Thank you very much, doctor.
okay, thank you very much. And still, in case if there are any more questions, you can send us, and we'll get back to you.
Yes.
Right.
I can even even get back the questions which I couldn't answer in that session. I could read the questions later on.
Okay.
Yeah. I don't know how to manage
Sure,
it,
if
but
any questions come up, then I'll email you the questions and then you can
oh,
answer
that's
them whenever
wonderful.
you
Yes,
have time.
we can. I can answer. I try to answer every questions. So.
Right. Okay.
Okay, thank you so much,
Okay,
Dr.
thank
Shin. It
you,
was a
thank you.
wonderful, wonderful session and a very nice Q&A session today.
Thank you
Thank
very
you so
much.
much.
Thank you so much. Thank you, everyone. Thank you.